going to talk to you again, like a steamroller, until I stop. If you have any questions, stop me and ask me. Yesterday we did allergy, today we're going to do asthma. There'll be similarities between the talks. So this is pediatric asthma for dummies. Okay, this is the easy stuff. We're going to talk about how to make the diagnosis and then how to do the treatment. If you have a question, shout. Okay, diagnosis. This is a typical history. You diagnose asthma 90+% times through the history. Typical history is that the child will come in and they've had a story of repeated chest infections. Okay? They've not had chest infections, they've had viral infections that have upset their asthma and given them bronchospasm. They get a virus from school or a sibling, and that lasts for a long time because it affects their lungs, and they get bronchospasm and they get sticky secretions and they do a lot of coughing. So the typical story is lots of chest infections, they last a long time, they last so long that it runs into the next infection. Small kids, kind of 2, 3, 4-year-olds, will have a viral infection every 2 or 3 weeks. So if it lasts for kind of 10 days, it does feel like it's a constant, permanent cold. They go to their GP, they come to hospital, they get given antibiotics, complete waste of time, probably bad for them, and they go back and back to the GP, up to A&E. One thing in the history is you ask about a cough. Okay, they'll say to you, he's got a cough, but you must ask, what is the character of the cough? A smoker's cough, kind of a rattly cough, that's not asthma. Asthma is a dry, irritating as well, kind of cough. These kids will cough all night. They'll keep themselves awake, they'll wake up the siblings, and they'll wake up everybody. It's a dry cough. It gets worse with exercise, when they go outside and they do cross-country runs in the middle of winter, worse when they get a cold, sometimes worse with animals and pollens, worse when they get excited, worse when they laugh. Okay? I was doing the asthma clinic, was it yesterday? No, 2 days ago, I'm losing track. And we had a little boy in there who the parents were saying his asthma was good, and he was running and fighting with his little brother, and he was absolutely fine. He was laughing, and there was no cough. So that's a good marker that his asthma is under control. Okay, we're going to go back to basics. We're going to talk about what is a wheeze. What is a wheeze? This is a bit where you answer a question. And you don't worry about the video, you'll be fine. What's a wheeze? What does it mean?
It's used to describe a noise which is made an expiration, and they say it's like polyphonic.
Polyphonic expiratory noise. Okay. What's a rhonchi then? Do you use the word rhonchi anymore? No? Nobody uses the word rhonchi? Fantastic. Do you do crackles or crepitations? That's good. Too many fancy old words in this. Okay, if you Google wheeze or wheezing, it will say a whistling noise. Okay, whistling in the chest during breathing when the areas are narrowed or compressed. You can keep going down the list, and it'll say it's a musical sound, more pronounced on the exhalation of air, so expiratory noise. Okay, it's also a doing word. Sorry, I've got kind of primary school age children. It's a doing word. It's to breathe hard, to wheeze, with a piping or whistling sound, as in asthma. So wheeze and asthma kind of link together in the definition. Rhonchi, we're not too bothered about rhonchi. Let's ignore rhonchi. Okay, difficulty breathing, whistling, obstructed airway. Okay, so this medical dictionary says that wheezing is a funny noise in your chest. That's as much as it will say. Anything that you hear under the chest. And actually that's quite as is the rhonchus, everything gets called the same thing. That's kind of how it's used. Any noise that a child makes, the parent will call it a wheeze. Okay, because they're all trained parents. They've watched Casualty and they've watched Holy City. Older than that, they might watch some of the other medical programs. So this lady goes to her doctors, and her child's got noisy breathing. Now she doesn't want to sit in front of this very intelligent looking doctor and say, my child's got noisy breathing. She wants to sound a bit better than that. So she says, my child is wheezy. Okay? Ask yourself, how does she know that her child is wheezy? Has she got a stethoscope? Did she listen to it? No, she didn't. She heard it with her ears. So she's describing an audible noise, but she's telling the doctor it's a wheeze, which the doctor thinks must be in his chest. So he thinks, okay, the child is wheezy. What did they tell me at medical school about wheezing? Wheezing is a sign of asthma. He's a big chap, he's got asthma. So you've gone from a child with noisy breathing straight to asthma without too much thinking there. All because of the difficulty in communication. Okay, so to me, wheezing, high-pitched whistling sound, heard best on expiration, breathing out, not dying. That's a different kind of expiration. Keep pressing the button. Heard with a stethoscope. Okay, not heard by a parent, not heard from the end of the bed, heard with a stethoscope. Okay, we need to be clear because you have noises that come off your airways in two parts. We split the airways into upper airways and lower airways. Upper airway noise is different to lower airway noise. It's produced in a different area. If you hear a noise from a patient or from anybody, it's voice box upwards. Okay? So if a parent hears a noise, it's an upper airway noise, and it's not asthma. So always beware when someone says, I could hear them wheezing from the end of the bed. Okay. Lower airway, whistling noise, asthma-like illness. Okay? Viral-induced wheezing, that kind of thing. Upper airway noise is my favourite diagnosis. You know how the surgeons come along and if the patient's got abdominal pain and they come along, they don't have to make a diagnosis, they just go, fiddle, fiddle, not surgical, and off they go. Well, that's my diagnosis. I come along and I go, listen, listen, not asthma, and off I go. It's not a real diagnosis. So what do patients mean when they say wheezing? Somebody studied this and produced a paper called Survey of Respiratory Sounds in Infants. Again, if you read the title, you might not go into it. This is from the team in Sheffield, and that's important. And they postulated that we've seen an increase in asthma. And I think I started talking to you yesterday by showing you a graph that had increased in atopic diseases, including asthma. They said some of that increase is because parents are using the word wheeze. They're saying that word to doctors, and doctors are translating that into asthma. And that's why we're seeing more asthma nowadays. So they did a little study to investigate the terminology used by parents to describe the noises. They found 92 infants with noisy breathing. So they looked at referral letters and said, infant noisy breathing. And they got hold of the parents before they got seen, and they asked them to choose from 3 different words. Okay? Now this is Yorkshire. So you had the word wheeze, you had the word stridor, not many people anywhere are going to use the word stridor, and they had the word ruttle, okay, which is, anybody from Yorkshire? Oh, someone from Yorkshire. No? Okay. Just me then, okay. So they have the word ruttle, which is a noise in Yorkshire for a rattly, crackly kind of noise in the back of your throat. If you Google ruttle, you will find this paper and articles on guinea pigs, because guinea pigs get ruttles, which is a kind of a snuffly noise up their nose. And they asked them to choose a word, and then they split them into the groups for the words, and they did some training with them. They showed them some videos of a child with a wheeze, a child with a stridor, and a child with a ruttle, which is upper airway secretions. And sometimes they did imitations of them all as well. I could do a stridor. I can't do a wheeze because I can't control my lower airways, and the parents wouldn't hear it anyway. I can't do a ruttle, because ruttle is all about snot and stuff, and you hold it in the back of your throat, and adults cannot do that until they're dying. You know, when you're dying, you have that kind of death rattle, and that's the same kind of thing. But as an adult, you will cough it out or you will swallow it. Little kids can just leave it in the back of their throat, and they just breathe through it. It just makes a really bubbly, rattly kind of noise. This is what happens. Surprise, surprise. every parent that came in, well, a big chunk of them, with a child that was had noisy breathing, said, my child is wheezy. After the training, it went from 59% down to 36%. So at least half the patients that came in and said, my child is wheezy, at the end of it decided that actually my child wasn't wheezy. My child had ruttles. My child had upper airway secretion noise. So we need to be very careful. And they suggested that this was part of overdiagnosis of asthma. So a ruttle, because it's produced by fluid moving around, that produces lots of vibrations. Asthma doesn't produce any vibrations because it's a very high-pitched sound. So if you hold a child and the child is having a ruttly, bobbly noise, you will feel the vibrations in their chest because the noise will be generated in the throat and will travel through the spongy lungs out to their chest wall. And the parents will say, you know, I can feel it in his chest. If you have fluid rattling around inside your chest, you will be in ITU, not going off shopping somewhere. Oh, this is really geeky, isn't it? Okay, off in the corner here, at the top, this team also did a study where they put microphones on children and listened to them. And this is the kind of pattern you get when you put that through an oscilloscope. So the top one is normal breathing, nice, smooth, in, out, kind of noisy. The middle one is almost like a musical note. That's a wheezy child, okay? Because you're blowing air through tubes of a fixed caliber. So you get a wheezing, whistling kind of noise, just like playing the flute or bagpipes or whatever it is you want to play. So it's a very consistent sound. The one at the bottom is a ruttle. And if you look at that, it's up and down all over the place because you've got different amounts of bubbles and different sized bubbles and fluid moving around. And that one at the bottom is going to produce vibrations that you can feel. So the next time someone says wheeze to you, don't believe them. Okay? Ask them what they mean. So let's try again. Okay, he's learned something. We're doing well. Okay, he puts on his policeman hat and he starts interrogating this poor mother. And he says, what do you mean by wheezing? And I can guarantee if you ask this question, 50% of the time the parents will say, well, it's like a rattle, yeah, in the back of their throat. You ask them, can they imitate it? Often they can, it's quite fun. Watch them try. And ask them if they can feel the noise. And they'll describe it as, it's like holding a boiling kettle, or like holding a bag of crisps. And that kind of constant movement. Okay, so that was ruttle, so don't get caught out by small, ruttly children. Ask about wheeze. So, here we are, back in the diagnosis of asthma. This is the British Thoracic Society sign guidelines. This is from 2003, I can't keep up because they keep updating it all the time, but this hasn't changed very much. And this is what they reckon you should be looking for children with suspected asthma. You ask about wheeze, you ask about a dry cough, you ask about breathlessness, you ask about noisy breathing, but you now know to be very careful when you're asking about noisy breathing. Oh, that was very exciting, wasn't it? Try again. So you've done your initial history, you go into a detailed history, you ask about the pattern, when does it happen? Does it happen on a cold day? Does it happen when they get a cold? What do you do about it? What have you tried already? Is there anything else it might be? So you might be trying to differentiate it from something like cystic fibrosis, so they can cough up sputum, are they losing weight? Have they been in contact with somebody with tuberculosis? That kind of thing. And you get all that in your head, and you decide, because there is no test for asthma, you have to decide whether you think it's asthma or not. And it's a kind of a balance. If the little child in front of you has got everything stacked against them, it's got 2 parents with asthma, the rest of the siblings have got asthma, the dog's got asthma, this child's got eczema and allergies, and it's got a cough that is very dry and gets worse when they get a cold, then they've probably got asthma. You know, if it's another child with no family history at all, and just a cough when they're out exercising, you know, maybe it's not. So some of them will be barn door, some of them you're not sure about. So you ask yourself the question. If you say, no, it's not asthma, it's a ruttle, for example, you do something different with it, which is generally nothing at all. If you say, probably, there isn't a definitely on here, if you say probably asthma, You'll go into the history a bit more and try and work out what causes it and what you're going to do about it. And then if you're not sure, you can do some other testing. Differential diagnostic testing. It says all trials of asthma therapy. So kids with asthma should get better with salbutamol. So the standard treatment would be, I think you probably get asthma, I'm not sure, here's a blue inhaler, go away, take a whole stack of it when you get a cough. If you get a cough, then you take 5 puffs or you take 10 puffs and see if you get better. If you get better, then you've got bronchospasm and you've got asthma. You can send them off with a peak flow meter and ask them to monitor that. And then you get them back, you decide again, is it asthma or is it not, and then you make a plan to treat it, which we'll come on to later on. Going back through the history, we've talked about all these things. We need to find out, are they an atopic family, are they an atopic child, asthma, eczema, hay fever, what else are they exposed to? Are they passively smoking? You can ask the parents, you can smell smoke in the room. You can even do urinary cotinine testing with a little dipstick. You just get some of the child's urine, dip it, and it will show whether they've got nicotine metabolites, telling you whether they're either a smoker or a passive smoker. You ask about pets at home. You ask about what the housing's like. Is it damp? Is it dusty? Is it out in the country? And then you ask about what medicines they've had already, because it's unusual for them to come up. I guess it depends where you are. It's unusual for them to come to me without any treatment at all. So you want to know what medicine they've had, did it work, how they took it, what they think helps. So what medicine they're on, how often do they take it? If it's an as-required medicine, what do they do? What tells them that it's required? You know, do they do it every time the child coughs, or do they do it before the child has PE at school? Ask what device they've had. There's a whole bunch of different devices, some good, some rubbish. And then the most important question is, do they help? Okay, often we start patients on these medicines, and I'll see them in clinic, and they've been taking these inhalers for 2 years, and I say, do they help? No. Are they any better? No. But it's probably not asthma then, it's probably something else. And then you examine them. They're not usually very helpful, but when they come up to clinic, they're not usually having an acute asthma attack, so you don't get any wheezing. It's unusual for kids to get changes in their chest shape, but that can happen. And you want to have a listen to them just to make sure they're not wheezy, because that will help you tell about your diagnosis. Have a look at their nose and in their throat, see if you've got anything else going on. Check their peak flow and make sure you've measured their height so you know what it's supposed to be. And very importantly, check what device they're using and make sure they know how to use it. Okay, you might have a fancy machine. This is an exhaled nitric oxide machine. Anybody seen one of these? If you have asthma, asthma is an atopic disease. Atopic diseases are characterized by eosinophils. Eosinophils are characterized by their ability to produce nitric oxide. There's nitric oxide in the air all the time, so it's not such a big deal. But if you can get a sample of lung air from these kids and measure their nitric oxide levels, you can tell whether asthma is active or not. We've got one of these machines. We're just going to get a new one because I've dropped the old one. So if you get high value, it suggests they've got asthma, and that's good for diagnosis. And if you've had them on treatment and they've still got high value, then you ask yourself, are they taking their medication? So, in a new patient, it would say asthma, not asthma, if you believe any test. You might still want to do a salbutamol trial. And in a treated patient, it says this patient's not getting enough steroid into their lungs. If you get a low score, you're either a smoker, because smoking completely knocks out all the nitric oxide, or you've not got asthma, in which case you need to think about something else, or you're a well-treated patient and maybe you need to have your treatment stepped down. So there used to be just one of these machines on the market. There's now about 4 or 5, so I would guess in a few years' time the prices will come down and it will be more widely used. All you have to do is just blow into the tube. It's just a breathalyzer. Okay, so that was diagnosis. Now we're going to go on to treatment. Any questions on diagnosis? No. Okay, here's a selection of your options of how you're going to give the medication to the patient. Which one are you going to choose? And 5. I've got asthma. Which one are you going to choose?
Depends what age the patient is.
Okay, I'm 5.
Oh, sorry.
I've got asthma.
A spacer and a metered dose inhaler?
Yes, that's the right answer. A spacer and a metered dose inhaler. Not a suspension. You used to be able to get salbutamol suspension. Rubbish. Okay, why would you treat your gut with salbutamol? So spacer and mask would be for a smaller child, so maybe a 1-2-year-old. After that, we can start to use a mouthpiece. So you've got a metered dose inhaler through a spacer. Okay, I've grown up now. I'm 10. What are you going to give me? Kids grow up really fast. 10. Sorry? Nope. That's the trick. Never metered dose inhaler on its own. If I'm 10, the best thing for me to take is, for my steroid, is a metered dose inhaler and spacer. Everybody who has asthma should take their steroids through a metered dose inhaler and spacer. I don't care how old you are, I don't care how good you think you are using a metered dose inhaler, it's not good enough. Most of it will go into your mouth and you'll swallow it. So every single asthmatic should have a spacer and a metered dose inhaler for their steroids. Slightly different for bronchodilators. They should all have a metered dose inhaler for bronchodilators when they're unwell, because they take it through the spacer. But you're not going to get a 10-year-old or a 15-year-old boy to go off to play football with his great big spacer. It just won't happen, he won't take it. So then you might move them onto a dry powder device, such as a turbohaler or an AccuHaler, which is a bit smaller and a bit more compact, and it's almost as good. I wouldn't use it for my inhaled steroids unless I really had to. I'll tell you how bad a metered dose inhaler is. I saw a patient yesterday who has something called eosinophilic esophagitis. So it's like a crazy allergic condition in your esophagus. The treatment for that is a metered dose inhaler. Okay, you take it, you squirt it, and because none of it goes in your lungs and most of it goes in the back of your throat, you swallow it down and the steroid just runs down your esophagus. So actually, using a metered dose inhaler is a really good way of getting steroids into your esophagus, and it treats eosinophilic esophagitis. It's rubbish for asthma. Never do it. Okay, nebulizers. I didn't even mention nebulizers on this, did I? I hate nebulizers. I can do a whole hour's lecture on why I hate nebulizers, but I won't subject you to that. Nebulizers, when I started in medicine in around 1990 something, everybody got nebulizers. You came to hospital, you got nebulizers. And then you went home. Then you got sick again in the middle of the night. What are you going to do? You're going to go back to the hospital for another nebulizer. And in the 90s we were still doing 24, 36-hour shifts, so I saw people in the afternoon, and then they came back and woke me up again in the middle of the night. And very quickly I thought, this is a rubbish idea. So I never liked nebulizers from that point of view. There's a real kind of voodoo magic mist about the nebulizers. They hiss and they kind of spray smoke. And they're very tying. Some people have home nebulizers and they won't go anywhere because they can't take their nebulizer, because it doesn't plug into the car, or they might not have a good enough electricity system. And another interesting fact is that if you use a nebulizer, you drop your saturations. You probably won't notice that, certainly in hospital, because we drive our nebulizers with oxygen. So you're swamped with oxygen anyway, so you don't get a drop in saturation. If you give a nebulizer at home or in the community as a GP, you will get a drop in saturation because they're all driven by air. And you can drop your sats by 4 or 6%, which can be quite significant. They need to be maintained. One of the first things I did when I came here was I had a nebulizer amnesty. And I wrote to all the patients with nebulizers and said, why don't you bring your nebulizers up, let's have a look at them, see if you still need them. And I remember we had one, to press it there. Okay, nebulizers are very expensive. Actually, nebulizers are free from the drug companies because the drugs are so expensive. If they can convince you to give someone a nebulizer at home, they'll make a killing. And in A&E, with a nebulizer, you put the nebulizer on and off you go. You go and deal with somebody else. So you've left a sick patient. and you've gone off to someone else, you only come back when you think the sound's changed on the nebulizer. And it's probably not the best treatment for asthma. This is what's been happening in paediatrics to do with nebulizers. So the black bar at the top is patients who came into hospital and through their entire hospital stay never had a nebulizer. Okay? It's gone from last millennium, a very small percentage of kids that managed that, to around 2005, when kind of heading for half the kids that came in never even had a nebulizer. Because the growing realisation that you don't need a nebulizer, and they're probably not as good as using salbutamol multidosing. Okay, I hate nebulizers. NICE hate nebulizers. They say patients should have pressurized metered-dose inhalers and spacers or a dry powder device before you even think about a nebulizer. This is what you should be doing. You should be multi-dosing patients. In 1999, everyone thought, did you hear about the Millennium Bug? And everything that vaguely might have been electrical or had a chip in it used to just crash and collapse on the 1st of January 2000 because it didn't know what millennium we're in. And some people worried that all the nebulizers that were given out to everybody were going to crash on this day, and it was going to be a medical disaster with all these people coming to hospital on the 1st of January. So they started to do some experiments, and they tried to work out how much salbutamol through a pressurized metered-dose inhaler and a spacer was equivalent to giving a nebulizer. And they found that it was about 5 puffs was equivalent to a 2.5 ml nebulizer, and 10 puffs was equivalent to a 5 ml nebulizer. And then eventually they thought, well, why don't we just do that then, rather than giving them a nebulizer? So this is how you do multi-dosing. You shake your inhaler. If you don't shake your inhaler, it does not work properly. Okay? So every inhaler should be shaken before every single puff. You then stick it in a spacer, and you do 1 puff, single puff, never 2. The spacer is specially designed to hold 1 puff. If you put a second one in, it just squashes the first one against the walls, and you don't get 2. You might get 1.2. So 1 puff, stick it on the child, and let them breathe for about a minute. A minute because then they will take everything out of the spacer. Some people would say 3 breaths would be sufficient to clear the spacer. Some people do single maximum breath, where you just do 1 big breath in. And that's fine for adults, not very good for small kids. And guys, you know, when you're spraying your hair with your hairspray, yeah, does the canister get really cold sometimes? No, you not try that? That's called a cold freon effect, when all the kind of gas comes out of the aerosols. And when you use a metered-dose inhaler, it cools the canister, and the metered-dose inhaler is designed to work at room temperature. So actually, you should wait a minute between puffs anyway. Otherwise, you'll get less and less every time, because you get less and less effect of the gas. So it should be a minute between every single cycle. So 1 puff, and then 3 breaths, or 10 breaths, and then another puff. So it should take 5 minutes to give 5 puffs, and 10 minutes to give 10 puffs. Okay, so this is standard BTS stepwise treatment for asthma. Number 1, child comes in, got a bit of wheezing, a bit of cough. You start them on inhaled, short-acting beta-2 agonists. So 99% of the time that's going to be salbutamol. You then arrange to see them back and see how they are. If they're absolutely fine, then that's what they stay on. And loads of people just open the inhaler at home and just use it once or twice a year, and that's absolutely fine. If they then come back and they say, well, look, we're actually using it 2-3 times a week, and he's still got problems coughing at night, that's when you need to step up. So you go up a step, you go to step 2, which is inhaled steroids. Usually we would start with beclomethasone, because that's kind of a good, cheap, safe inhaled steroid, and you'll give the beclomethasone 50 inhaler, 2 puffs in the morning, 2 puffs at night, which adds up to 200 micrograms in a day. And that's a good dose to start on. We used to say go in high and then drop it down. Actually, nobody ever drops it down. When kids get better, you don't put the medicines down. So the safest thing is to go in at 200, and if they're not better in a couple of months' time, step them up. And then he comes back to you and said, yes, he's better, that's great, thank you, goodbye. No, you don't say goodbye, you say, okay, he's better. Is he 100%? Can he do everything that his non-asthmatic classmates can do? If the answer is yes, then that's fine. He stays on his beclomethasone. But if he can't do everything that they can do, or everything that he wants to do, then he's not controlled. He's not got complete control. So then you'd need to step up again. And then you get step 3, which is really messy. They need to kind of break up step 3 and have a few more steps in it. First thing you would do is you would add in a long-acting beta-2 agonist. So salmeterol, something like that. That's a standard one. And then assess them again. If they get better with that, absolutely fine, leave them on that. If they don't, then you start thinking of some other stuff. And the other stuff on the bottom there is leukotriene receptor antagonists, which in children would be Montelocast, or theophylline, which we don't tend to use because they get a lot of side effects, but we do have 1 or 2 of them. Let's say you've done all that and they still come back. What you can do then is just increase the steroids. We know that increasing steroids is not a particularly good thing to do, because you hit a ceiling with steroids whereby you don't get any extra benefit, but you've given them everything else. What else can you do? And then if that doesn't work, you're looking at giving them a daily steroid tablet, or long-acting steroid injections, or methotrexate, cyclosporine, kind of crazy stuff, whatever it is. Then you're in real trouble. I don't have anybody on a daily steroid tablet, but we do have some patients on more expensive anti-asthma drugs. And then the plan is always that you step them down. Usually, the parents step them down themselves, because they say, actually, it's been really well, we forgot to pick up the inhaler, or we went off for a couple of weeks somewhere and he was absolutely fine, so we just never really carried it on. And most people will stop their own medication. Okay. Other things you need to remember is that inhaled steroids can affect your growth. I think I mentioned yesterday about a little chap who was getting loads of steroids in various orifices, who had issues with his growth, and problems with adrenal suppression, which is the bottom one there. Every child that comes to our clinics gets their height measured anyway, but in particular, we should be concentrating on kids with inhaled steroids. Okay, talked about inhaled steroids. Sometimes you might hear patients who are told when they get problems with their asthma, when it's starting to go off a bit, they should double their inhaled steroids. That's another rubbish. Okay, somebody made that up one day, so that was a good thing to say to get people out of the surgery. But it's not. They've done lots of studies on children, and they said to half the group, just carry on doing what you're doing, and the other half, when you start to get going, to double your inhaled steroids, see how you get on. They get on exactly the same as they did with kids in the other group, so it's completely ineffective. Which logically, when we start inhaled steroids, we say to parents, you won't notice an effect on this from this drug for a couple of months, because it takes that long to get into your system. Why it would suddenly start working in a few hours is kind of logical. And here's another, this is an adult study, but the results are so good. It's difficult to tell those 2 lines apart, but they're the bottom 2 ones there. So one is adults started on fluticasone, another inhaled steroid, at 250 micrograms BD, and then the other group is patients started on the double box. This is going in at a high dose of inhaled steroid and seeing what effect you get, and it's exactly the same. There's no difference in those 2 groups whatsoever. So giving patients a high dose of inhaled steroid doesn't make any difference, because there's a ceiling. So always give them the lower one. The more steroid you give them, the more side effects they'll get. What you really want to do is to give the lower dose of inhaled steroid with salmeterol, a long-acting beta-2 agonist. And that's the effect you get from that. So you get an instant jump in your, well, this is morning peak flow that they measured in this study, and that's about 35. That's a significant increase that patients will actually notice, which will hopefully help them be compliant with their medication if they notice a good benefit from that, and that's sustained through the length of the study. So don't just put people's steroids. Okay? It's generally not the best thing to do. Think about something else. Okay, you might also come across a medicine called sodium chromoglycate. You might find some older adult patients on it. It's a load of rubbish. We stopped using it in peds probably about 10, 15 years ago. We used to always start with sodium chromoglycate because there was never any side effects from it. Probably because it's completely ineffective at doing anything at all. So it wasn't even good enough to give you a side effect. You used to have to wait for months to see if there was any effect, and there never was. The device was rubbish, it had little razor blades in it, which was probably not the best thing to give to kids. So it's just a waste of time, so we chucked that one. Leukotriene receptor antagonists, so Singulair and Accolade for teenagers and adults. Quite nice drugs, pretty safe, pretty easy to give. We're not, well, I'm not entirely clear how they work. They have a bronchodilator effect, but they also have some kind of anti-inflammatory effect as well. They can improve your peak flows and your symptoms very quickly. They are licensed for add-in therapy. You might get told they're licensed for monotherapy on their own for asthma, which is generally not true. They're only licensed if you've tried inhaled steroids and the patient just cannot, for some reason, do inhaled steroids, which is pretty unusual. So they're very rarely licensed for monotherapy. And we use it at step 3. So problem patients already had inhaled steroids, like and bronchodilators. The important thing about leukotriene receptor antagonists is some people have the wrong kind of asthma and the wrong kind of inflammation. And for them, leukotriene receptor antagonists are completely ineffective. It's a waste of time. Some people will find it absolutely fantastic and say it's like flicking a switch and their asthma just disappears. And other people come back after 6 weeks and say, this is a load of rubbish. So you need to give them a trial and you need to follow them up and see if they're any good. If it works, they carry it on forever. Fantastic drug. Okay, this is a bit of a historical document. This is from the mid-90s, just when we were starting to use Montelocast Singulair. This is a Glaswegian teenager. She came to our evening asthma clinic and said, my asthma is really bad. And we said, well, why don't you try this new medicine? It's just come out, have a go with it. Let us know what you think. Check your peak flow and we'll see how you go. So it was an evening clinic. We gave her a prescription, off she went. There's no chemist open, so she took it home. She didn't go to the chemist for a couple of days because she's a teenager and she's too busy. And then when she got to the chemist, they said, oh, that's a new drug, we don't stock that. It took a few more days to get it. So you actually get maybe 2 weeks of her peak flow measurements, because she started doing them straight away before she starts taking new tablets. That's what it says. At the start is taking new tablets. And you can see what her peak flow is like. Okay. Loads of variability, up and down, absolutely rubbish. And she started taking these new tablets and she said it was like flicking a switch. My asthma just disappeared overnight. You can see all that variability just went completely away. She got a tiny little flicker of variability, probably entirely normal with a bit of a morning dip. So for her, this was a fantastic medicine. For someone else, waste of time. You cannot predict who's going to get benefit from it. We used to think it was the atopic types, but actually you've just got to try it. So the only real side effect you can get from it, a bit of tummy pain, a bit of headache, same as any drug, but sometimes it gives them very weird dreams. I did have one patient who, whenever she took the tablet, she dreamt about killer ducks. She was only about 3 or 4. And she'd wake up terrified that the ducks were getting her, we stopped the medicine and she was absolutely fine. So beware of bizarre dreams on medicine. Okay, so looking a bit closer at step 3, it's all about adding in bronchodilators and reassessing them. I think we've done all that, haven't we? Yeah. Get off, we've done that. Okay, we've done that as well. Right, so let's say you've gone up your steps and you've given them loads of medicines and you're a bit worried about how much steroids that you're giving them and they're still not getting any better. What are you going to do? You're going to go back to the beginning and you're going to say, have they got asthma? If I genuinely think they've got asthma, because I've seen them having acute exacerbations and coming into hospital, why are they not getting better? Asthma drugs are fantastic drugs. There's loads of different ones. Generally, if you take them, you get better. So the question is, are they taking them at all? And do they have the correct device? So we need to work out which device they're using, making sure they're not using a meter-dose inhaler straight away without a spacer. One good question is, do you have your inhalers with you? Can you show me? And if they haven't got them with them, maybe they're not taking them. And if they pull out just a meter dose inhaler without a spacer, then that suggests that maybe they're not. I always ask patients how many times they forget, because everyone forgets to take their medicines. You know? And if you say to them, do you forget to take your medicines? They say, no, never, I take them every day. And you know, kids' lives are so complicated, they will forget them. You know? So you say, how many times a week do you forget? Once, twice, 3 times. And parents look at them like, terrified. So you can help their compliance by making their regime simpler. You know, so maybe some of the older medicines used to be 3-4 times a day, which is rubbish. Nobody can take medicines 4 times a day. There isn't enough hours in the day to do it 4 times. So you try and make it more straightforward. If I'm looking after siblings, as I'm after man, I try and have them on the same medicine at the same time as the same drug. Just because it's easy for mum thinking, whose inhaler is this, who's on the orange and who's on the purple. And then make sure they've got an asthma management plan, a written down plan that tells them exactly what you want them to do. Here's a nice little study where they gave patients with asthma an inhaler with a timer on it. And they said, this is an inhaler with a timer on it. It will tell me exactly how many doses you take and when you take them. So off you go and do your usual thing. They had patients on 4 times a day inhalers, that would have been in town, and they got 18% compliance. Waste of time. 3 times a day inhalers, get 30% compliance. Twice daily, you might get 71%, which is pretty good. This is asthma medicine. You don't usually get an instant benefit from it, so people don't always remember to do it. We know that cancer patients forget to take chemotherapy, and you think they would be 100% compliant to try to stop themselves relapsing, but you know, even they forget. So something like asthma is not surprising. So you need to make it as easy as possible. Some of these patients were sitting in the clinic outside because they had timing on it going puff, 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 just to kind of make the numbers right. They were clearly not taking anything at all. So, if we see a patient in the ward with asthma, then that's a failure, because they should have been kept out. All the idea of all these medicines is to keep you well and keep you out of hospital. So if they come into hospital with asthma, we should be doing something different. Otherwise they're just going to go around and come back again. When you go home with asthma, you should have 3 days of prednisolone. If you're over 5, we should think about giving you a peak flow meter so you can monitor your asthma. We should make sure that somebody's going to follow you up and make sure you actually get better, so the GP or the hospital. And if they're admitted on prophylaxis, then the prophylaxis didn't work. So you need to think about, do you need to cut that out? Sometimes you find that actually patients come into hospital, we don't understand what they've been taking, actually go home on less medicine than when they came in which case they are bound to come back again. And you need to think about whether they need some emergency steroids at home. I have lots of patients who have 4 prednisolone tablets at home, because asthma always gets worse at night time. You know, so mum's up at night time because dad's always asleep. Mum's up at night time, the child's coughing, she knows she's going to take to the GP in the morning, she knows the GP's going to give them steroids, and you just give them steroids at 12 o'clock at night. And if you go to the GP and he says, no, it's not asthma, it's something else, well, you give them 20 milligrams of prednisolone, who cares? You know, so make sure these people have got some emergency steroids at home, and make sure they've got an asthma plan that tells them, you know, about the peak flow, that tells them when they should be taking their inhalers, when they should take prednisolone if they've got it, and when they should panic and come to hospital. I think it also tells them how they should come to hospital as well. When these patients are sick, you know, they come to hospital in an ambulance or they go to see their GP. They don't come on a bus. Asthma and pets. Some people with asthma will be allergic and they'll be allergic to their pets. Pets produce huge amounts of allergens. Again, we talked about cats yesterday. You can avoid pets. This room probably hasn't had pets in it. It's something, though. But there will still be cat in this room, and there'll be dog in this room, and there'll be all sorts of stuff in this room. So buildings that have never had pets in, or public transport, will also be full of pet allergens. My son, I think I mentioned, is horse allergic. Whenever he sat next to a particular girl at school, he used to have problems with his breathing and his asthma. It took us ages to figure out that she was going and do the horses in the morning, They come in and sit down, and when they do certain lessons, they sit together. So some American schools actually have pet-free classes for their allergic kids and asthmatic kids. So if it's big enough school, you say, if you've got a pet, you can go there, they've got a pet, you can all go in this classroom and keep all the asthmatics in there. And they do significantly better if you do that. We don't realise what's around all the time. So what are your options? Get rid of a pet, kill a cat, wash your pets regularly, keep your pet and your asthmatic patient in a carpet-free room, so all the kind of dander and hair and stuff can be swept away or blown away. And when you're hoovering the floor, you need to make sure that you've got a proper filter on your hoover, like a HEPA filter, so a Dyson or one of these other cyclone ones, not one that has a bag that just recycles the small particles, so that will just make you worse. Okay, here's an asthma plan. There's lots of different asthma plans that you can find on the internet. Often they will have a traffic light on them, and the traffic light will be based on either symptoms, so at the top, your breathing's good, you're not coughing, you're not wheezing, you're in the green zone, your peak flow's what it should be, so for this patient at around 200, just take your medicines. It lists explicitly what medicines we think they're taking. When your peak flow starts to drop, or you start to get symptoms, coughing, using your inhaler more often, this is where in the past you might have been told to double your inhaled steroids, but we know that doesn't work, so we say to them to start multidosing. You take 5 puffs, or you take 10 puffs. Don't mess about with salbutamol, give them 2 mamby puffs, give them 5, give them 10, and tell them to get on with it. If they're having to do that quite a lot, or they're coming down into the red zone, so their breathing is getting very difficult, they can't walk, they're getting nasal flaring, they're multidosing every 2 or 3 hours, they need to come to hospital. You need to carry on the multidosing, take some steroids, keep calm, and then in big red letters, get out from a doctor or call an ambulance. Okay, troublesome asthma. Think about other things. Think about cystic fibrosis. Really, really unusual for an asthmatic to actually have cystic fibrosis instead. It used to happen all the time, but now we screen for cystic fibrosis. In fact, we've screened in East Anglia for 25 plus years, so you really shouldn't find any of that here, unless they move in from abroad. But cystic fibrosis is very much a Caucasian problem. You do find it in some Asians, but very much a Caucasian problem. So most immigrants wouldn't be at risk of cystic fibrosis. It's very much the local population. They would present with chest infections, loose stools, diarrhea, and finger clubbing. We used to find this all the time before screening, but now the UK screens every single baby for cystic fibrosis, so you shouldn't get surprised, and the screening is very good. Think about gastroesophageal reflux, both in little babies that are refluxing a lot, but also in older children. Often they're kind of sicky babies and then they kind of grow out of it, and as they get older, they've still got loose bowels and they spill a bit of liquid when they lie down or when they exercise, and that makes them cough, and that can look very much like a night cough or an exercise-induced cough of asthma. So think about gastroesophageal reflux. Some kids with asthma get better when they're treated with proton pump inhibitors like omeprazole. Think about snot. Okay, if you've got snot in the back of your nose, you've all seen snotty kids and it's running down their face. Some kids do that all the time. When they lie down, it can't run down their face, it runs down the back of their throat. And it sometimes runs and sometimes it drips. And it makes them cough and it splashes around and gives them nighttime symptoms. So think about ENT disease, rhinitis, snot. Think about vocal cord dysfunction. You ever heard about vocal cord dysfunction? It's a funny old thing. There seems to be various different flavours of it. Vocal cord dysfunction involves making a wheezing sound with your vocal cords. So just like an actor does on the City, they come in and they're never completely silent. They kind of go, yeah, and that's what people think wheezing sounds like. So you will come across patients who make that kind of noise that will sound like a wheeze in their chest, either because they want you to think they've got asthma, or because they get stressed, and when they get stressed they get vocal cord tightening, and they get into a bit of a panic. I remember one little patient. She was very small. She was only about 4 or 5, and she was on loads and loads and loads of asthma medicines, and she just wasn't getting any better. I went and listened to her one day, and she sounded really wheezy. And I got my registrar to go and listen to her, so I stood and watched, and she sat there quite happy. And as soon as he put his stethoscope in his ears, put it on her chest. You know, not normally kids kind of breathe normally, and she went, as he was listening. And when he stopped, she stopped. So he never noticed at all, because all he heard was the noise when he listened. But when you're watching, it's very clear she was making a noise when she was doing it. And I don't know if she was doing that because she thought that's what he wanted, or because she wanted to be wheezy, because the rest of the family all had asthma and she didn't. That's a bit sad, really, isn't it? So she wanted to have asthma, and that's how you got tension in that family, was by wheezing. Kids are funny things. Okay, that is the end of my talk. Do you have any questions? Yes, question, Ben.
Is there any evidence that changing, for example, from one type of level to another, does that have any sort of effect on control? Is it like trying different types of...
No. No. Generally, I like to keep things simple, so I know what the patient's on. So if they come to me, I will stick with a particular company. So when they say to me, you know, brown inhaler, I know what they're taking. So I would tend to go with salbutamol, beclomethasone, and then I'd move them on to serotype, which is a fluticasone and salbutamol combination. So all my patients will be on that. Some of the older ones might go on to Pulmicort or Symbicort, but usually I try and keep to a small number of stuff, so I know what devices they've got. Otherwise, you can have patients on 30 different devices and 30 different medicines. You know, so you don't know so much about them, and you don't actually know what they're taking. So I wouldn't switch somebody. I wouldn't switch steroid either. I would step up a steroid. I'd go from beclomethasone to fluticasone. Or I wouldn't go from beclomethasone to Pulmicort. They're all very much equivalent on the various runs. Any other questions? There you go. That wasn't too bad, was it? Okay, thank you very much.
Press the button, a red thing comes on, and then you can see one or two.